this, then look for a box that says pulse oximeter. It's a tissue box, and we put a picture of it. And so I don't know who's going to utilize pulse oximeters that day, so don't freak out, because I think we only have 4 of them anyway. So if there's one being used in the lab, then it might be you, okay? So let's just start over. And we'll just leave that up, okay? So, knock, knock, knock. Good morning, how are you? My name's Sunny Costa. I'll be your nurse today. Wash my hands. And I require to shut the door or whatever, but I'm not going to because it's in my way. I know that my patient is not in a safe position because the bed is actually all the way up and it stands locked, and there's a rail here, but I'm here, so I'm fine. I'm going to do an assessment on you. I'm going to listen to your heart and lungs. Could you please give me your name? Mr. Jones. Okay, can I call you Mr. Jones or shall I call you Charles? Alrighty, and your birthday? Okay. And you're allergic to Demerol, it says, is that correct? Okay, great. Alrighty, well, I was wondering, do you know why you came into the hospital today? Okay, chest pain? Alrighty, on a scale of 1 to 10, what is that chest pain? A 7? Alright, I'm gonna go ahead and take your temperature. Put a little thing on your finger here. Sorry. This is probably already leaved, so for the comfort of the patient, I'm going to take it off and the reading. I'm going to get a blood pressure. I need to write that down. I can write it down. And then we go ahead and get a pulse. I'm going to use my watch, which is routine. And I'm going to do it for 30 seconds. Make sure that when I do it for 30 seconds that I multiply it times 2, because it's always out of a minute. Because this is a mannequin, I can listen verbally. But I'm going to use my stethoscope just to make sure to get a respiration sound. I'm going to count my respirations. Count it for 30 seconds, and I'm going to multiply times 2. I get that? I'm going to go ahead and write my stuff down so I don't forget it. My temperature. Pulse ox. Get the reading. 95. Okay, you said your pain was a 7, right? Alrighty. Okay. Mr. Jones. How did you sleep last night? Have you had any visitors today? Okay. Alright, I'm going to go ahead and I'm going to be shining a light on you. So if you could just look straight forward, that'd be great. I'm looking at the patient. The skin of the patient looks equal everywhere. He doesn't look like he's using any accessory muscles to breathe, and there doesn't look any nasal flaring. He looks like he's doing fine. He's stable. I'm going to start with Perla, and I'm going to shine my light into his eye and see that this eye constricts, and do it again to see that this eye central constriction. We go on the side and do the same thing. And his pupils are round and are equal and are about 4 millimeters. I'm going to go ahead and look up his nose, and I see that his mucous membranes are slightly more beyond pink in the nasal area. That's fine. His nasal septum is straight. His mucous membranes are moist and pink, and that's good. I'm going to go ahead and have him turn to the side here, and I'm going to look for neck vein distension. In this area here, I don't see it. I don't see any accessory muscle use either. I don't see any pulsations going on, and I don't see any neck vein distension in there either. I see that his trachea is midline to his neck. And I'm going to go ahead and, I forgot one thing, I'm going to go ahead and check for accommodation. I can do that 2 ways. I'm going to have the patient go ahead and just look at the pen, and I'm just going to move the pen here straight forward. And when I do that, the patient constricts and he converges. I'm going to go ahead and I'm going to touch you now on your chest. I'm going to palpate bilaterally with the fingertips of my hands, and I'm going to use circular motions starting above the clavicle, the ABCs of the heart, of the lung. And I'm going to go all in the spaces of the intercostal spaces. Mr. Jones, please tell me if you have any pain or tenderness while I do this. I'm looking also for masses and for tumors. I'm going to go in all the intercostal spaces all the way down to his chest. Okay, and he doesn't have anything, so I'm going to go ahead and do percussion. Percussion is indirect over the lungs. And I'm going to start over here above the clavicle. And when I'm over regular lung fields, I expect to hear resonance. And when I get over any solid organ, I'm going to hear dullness. If the patient had any hyperair, then I would hear hyperresonance. Going all the way to the base of the lung. Okay, so I heard resonance. I'm going to go ahead and use my stethoscope, and I'm going to listen to his lungs now, starting above the clavicle. I'm going to let him take one full breath in and one full breath out, so I can hear the entire process. When I place the stethoscope on your chest, would you please take a deep breath in through your nose and out through your mouth, and please let me know if you get dizzy. You don't have to listen for the full minute, for the full breath. Just for time's sake, once you get the sound, is fine. Okay, his lungs sound good. I think it's probably normal sound. I don't hear any adventitious sounds. I'm going to go ahead and start with my cardiac assessment, and what I'm going to start with is the carotid artery, and then I'm going to check for a brewery on both sides. A brewery is when the blood is turbulent blood flow through plaque, and I don't hear any. I'm going to go ahead and do my cardiac assessment, and I'm going to go ahead and find my landmarks, particularly for this, the sternal notch and the xiphoid process, the clavicle and straight under clavicle is the first rib, and right there would be my first intercostal space, and then my second. So my second intercostal space, right sternal border, is my aortic valve. My aortic valve in this area will be an S2 louder than S1. And I hear a murmur. I'm going to go over to the left sternal border, second intercostal space. That's my pulmonic valve. S2 is louder. And I'm going to go to Erb's point, which is third intercostal space on the left sternal border, and S1 and S2 are equal to each other. I'm going to go down to fourth intercostal space, and I'm hearing my tricuspid valve, and now S1 takes over and is heard louder. I'm going to move mid-clavicular line down to the fifth intercostal space. Here's my mitral valve. S1 is louder. This is also my PMI, where I can palpate the PMI, and if I located the PMI, the point of maximum impulse, and it was over toward the lateral side, then it may indicate that his heart is enlarged, as well as finding a bigger area of percussion dullness. While I'm here, I'm going to go ahead and do an apical. I'm going to take an apical for 60 seconds. And after I do that, I'm going to go ahead and check the apical with the radial. I'm listening for every heartbeat. Do I feel a pulse? If that is not the case, then the patient does have a pulse deficit. And he doesn't. I'm going to go ahead and look at the sixth spot. The sixth spot is the epigastrous area. I don't see any pulsation going on. Go ahead and palpate lightly to see if I see a pulse, or feel a pulse rather, and I don't. Okay, Mr. Jones, wow, thank you so much. Is there absolutely anything I can get for you or do for you? All right, I'll see about what pain medication that you might have. Checking my patient one more time, got all of my equipment. My patient's hooked up to whatever he's hooked up to, and my patient's going to be safe. I'm going to put him down to the low position with his rails up. And if I have a call light, which you know very well, I'm going to put the call light and tell Mr. Jones your call light's right here. You call me if you need anything, all right? Thank you. And I'm going to go chart.
Okay.